This is my supraglottic airway checkoff. Usually the supraglottic airways are categorized as blind insertion tools. This is because you don't really have like a line of direct observation in order to look down into the patient's mouth or throat. So the purpose of this is to create a seal in the pharynx and obstruct the esophagus, which will open up or force air into the trachea. Some precautions that you're going to be aware of when using one of these is the patient's gag reflex, making sure that nothing comes back up that would obstruct the airway. No reuse. This is usually for a single time thing. Obviously you can use it no more than 3 times on one patient, but it's important to discard of it after it's removed. Even after this is inserted into the patient, you're going to continue to monitor their respiratory rate, such as depth, symmetry, stuff like that, as well as their vital signs, so heart rate, blood pressure, stuff like that. And when inserting, you don't want to apply any unnecessary force or try to, apply pressure to really get it inserted in there. That would disrupt any soft tissue or anything. Inserting, so you're gonna grab the appropriate size. Typically in the athletic training setting, we only have a couple sizes available, whereas like EMTs and stuff are gonna have a bigger option, but you're gonna get this size based on the chart that comes with the devices. It's based on height, but so then you're gonna, in the King's device, it's similar to this but has a bladder on it. So before you insert it, you're going to want to check for, it working properly. So you're going to try to inflate it, and then you're going to remove all the air from it before you try to insert it. You're going to have a backup ready, especially if you're using the King's device, just in case something goes wrong. You're going to have someone else have already prepped that one as well. So then you're going to apply lubricant to the posterior side to allow for easy insertion or easier insertion, and you're also going to apply it to the tip. You're going to pre-oxygenate it, and you're going to check for any gag reflexes throughout the whole process. You're going to put your patient in the sniffing position. He already is up there, but so kind of like the head tilt chin lift, similar to that, but making sure that they're really back there. And then you're going to rotate it laterally, like 45 to 90 degrees, to allow for it to seal off that tongue. You're going to apply some pressure, but not where any, not if you feel resistance, because you don't want to break or disrupt any of the soft tissue. So you're going to keep pushing it. This lid right here, whatever, is going to kind of determine your size and how far you are in there. This one is probably a little big for him, to be honest, because I have to apply resistance to it in order to get it down to that. But you're going to leave it there. And then you're going to advance until it's in line with the mouth. From here, you're going to apply your bag valve mask or any supplemental oxygen that you are using at the time. You're going to apply it directly to there. Actually, before that, you're going to put it in place. Usually by using some form of cord, cloth. Usually if you're an EMT, you're going to have, a certain item that you're going to use. But you want to make sure that it stays in place. Then, going to use your bag valve mask. And then, you're going to want to make sure that if you're feeling any resistance in the air going in, that you can slightly withdraw it just a little bit at a time to make sure that the air going in is easy flowing. And then you're going to go 1/2 to 2/3 of a pump for an adult, otherwise 1/3 of a pump for a child. And then removal of the airway is usually done by advanced medical personnel because they have advanced equipment, as well as they're already in an extensive care setting, so they're going to have regulated the reason for why they needed to have this in the first place.